Second, please. Pause it. So I'm going to show you a video. It's about a traumatic GRT case. I'm going to show you my approach to it. I know there's lots of controversy and discussion about different ways to manage this, but this is my take on it. So this is a middle-aged man who presented with a GRT and retinal fold detachment. We didn't know whether the fovea was on or off at the time. I'll show you during the video. This patient was actually amblyopic in this eye. He had cataract extraction and he was left aphakic. And this is one of the reasons I think why he presented with such a large GRT around 9 clock hours. So you can see I'm doing the vitrectomy. The remnant fibrotic capsule was floppy. I'm trimming and shaving the vitreous over the edge of the detached retina. I think it's very important to remove as much vitreous as possible, as close to the edge as possible, with care and precision. I tend to lower my vacuum here. Now I'm removing the remnant of the fibrotic capsule carefully with a pair of forceps and just cutting the zonules rather than just ripping it off to avoid further damage. And as you can see, I'm successful in removing this fibrotic capsule carefully. Now, going back into the retina, doing a meticulous search, first of all, to locate the extent of the GRT and to also locate the horns of the GRT. I think the horns of the GRT should be treated very well too, because there is a tendency sometimes for the tear to extend later on beyond that area. So again, the vitreous is removed carefully and the search is completed. I prefer to use PFCL to return the retina to its physiological or near physiological location. I've done it in different ways, but I think doing it with the PFCL is the best way to reduce the risk of retinal displacement and or rotation. So when I fill the vitreous cavity with PFCL, I make sure, now I'll show you with indentation, that the edges of the GRT are flat, and then I start my treatment. So this is obviously me filling the eye gently and slowly with the PFCL, and now doing a couple of laser rows. I think 2 laser rows across the area of the GRT is enough. You don't have to do heavy laser. Remember, these patients are prone to get PVR. They're at high risk to get PVR. You don't want to be doing excessive laser to increase the risk of PVR. The horns of the GRT, I tend to cryo. So I do a couple of rows around the horns, and then I apply cryo to the 2 horns of the GRT. Now, what I do here is I basically leave the PFCL inside the eye for about a week. I don't like to leave it for more than a week because it's inflammatory, so I leave it in there for a week. I use a bubble in the AC to make sure that I haven't overfilled the eye with PFCL, and I advise the patient to stay on their back as much as possible. At the 1 week, I see them again, and if everything is okay, most of the time it is, I do a PFCL and gas exchange. Thank you.
Thank you, Dr. Ziad. I think like father, like son. And Dr. Ashraf, do you have any comment about the topic?
The GRT is very challenging cases, and I think that the idea of direct PFC silicone oil exchange is just very helpful to avoid the slippage and re-operating on the case from the start. Some people think about PFCL air exchange first, but I think if you get once a slippage, you will regret it and go for the direct PFC silicone exchange.
This is exactly what happened with me. So I've done the direct PFCL oil exchange. I think it's very fiddly, number one. Number two, I think you can only do it on the Alcon vitrectomy machine. With the Bosch and Lomb vitrectomy machine, you'd have to have a third hand to do it manually. You can't do a direct heavy liquid oil exchange. With the air, I've done it once. I've had a bad slippage and never again. And I'm sticking with the PFCL for my approach.
Please.
I want to add something about this technique for exchange. Beautiful surgery, but I want to inform you that for all cases between 100%, you can use PF cell exchange by air or for all patients with the GNT with or without PVR. It's useful and without any slippage. In my experience, over 20 years, I use usually PF cell exchange with air, and after this, I have a choice to use gas or silicone independent of the localization of GNT. Why? Because the secret is very simple. The secret is to attend to wait for some few seconds and few minutes when your PF cell cover the GNT. When you use your exchange by air, to wait in like in macular hole, to be a dry eye over the edge, and after this you can leave your PF cell by air, and after this you have a choice to use silicone or gas.
Can I, Abdullah? Can I want?
Dr. Hassan.
Yeah. So, Zaid, very nice presentation. So, I just want to correct my understanding, just a humble comment. I never ever use air in GRT. There's no logic of doing it, because even you don't get slippage, why to use it when you are using the perfluorocarbon liquid? That's the one thing. Second thing is that I don't find much logic if you don't have a PVR, leaving the perfluorocarbon liquid. Reason, chloride is exposed because of the GRT, already big tear, lot of inflammation. PFCl creates more inflammation than any other thing. So you are generating the three things that are creating more inflammation. Inflammation ends in the PVR. So these eyes looks very good on the table. These eyes looks very nice on the next 3 days. But after 5 months, how they behave? Ciliary body shutdown, lot of PVR. So try to get minimum inflammation from the surgical trauma, from the laser, from any liquid, from anything. So then you will have a long standing. The object is not to attack the retina. Object is to give the vision to the patient for long standing time. Thank you so much.
Could I add one comment?
One comment.
Because we don't have enough time. Very nice presentation. We have two ways. Either you put silicone, but to avoid the slippage, you pointed the trocar, because you can inject the silicone through different type of. We have 3 trocars. You choose which position has perpendicular, so the silicone drop on the posterior pole, then go to the periphery. This is avoiding the slippage. Otherwise, you can do the PFCl silicone exchange with any machine by using the infusion line. It's off-label, we know that, but it's always work in all the machine actually, not necessarily with Alcon. Thank you for this nice presentation. Our next speaker, Dr. Hassan Al-Dhibi, he's going to talk about